Hi, everybody. Welcome back to another episode of Hybrid Healing Hour. Today, we are going to be discussing osteoporosis with Dr. John Neustadt. Hi, John. Welcome on.
Hi, thank you.
I'm super excited to be talking about this topic because I feel it's scary. It's really particularly scary for women to be diagnosed with something like this. So I, we've read your book.
We've heard you on other podcasts, and we're very impressed with the information you gave. And it's information that a lot of people are not getting from their doctors. And so hopefully we can set the story straight on osteoporosis.
Wonderful.
So why don't we just dive right in? Why don't we start with just explaining to our audience, what is osteoporosis?
Osteoporosis is a condition where bones are becoming weaker, and it predisposes people to fractures. It really is a condition where the most dangerous thing is breaking a bone, and that's clinically what we should be focused on. But unfortunately, most of the time, doctors are not focused on that. They're primarily focused on just changing test numbers. So I know we're going to dive into all of that, but that's a really important thing to understand, that really it is about fractures, and that should be the main focus.
You know what, John? I'm sorry. I have to back up because I did not ask you to introduce yourself. And I want all of our audience to know. I jumped right into saying you have a book and how we've met you, but please, will you tell our audience how you are such a highly qualified professional in discuing bone health?
Yeah, how did you
us?
get to where you are today?
I love it. We jumped right into the meat.
I know. I got so excited.
Which is great. Which is great. I'm always happy to talk about osteoporosis. Talking about myself, I don't really talk about me that much, but just to introduce your guests to me and who I am. I've been focused on bone health and osteoporosis for the last 20 years, and I never thought I would be getting into this subject, let alone as deeply as I have. But when I was, fresh out of med school and in my private practice in Montana, I was having patients coming in to see me. They had, different conditions, but also osteoporosis. My mother-in-law at the time had osteoporosis, and she was 93 when she passed away just this last year. But 20 years ago, she was on Fosamax, which is still the first-line therapy and standard of care. And her physician was happy because her bone density was going up. And she was happy because her bone density was going up. I was giving her some nutritional recommendations and some exercise advice as well. But I was happy too because her bone density was going up. And then she tripped over a throw rug and fractured her hip. And I thought to myself, something is wrong with this picture. And so I dove into the research to try and help her. And I was shocked by what I found. The bone density test only predicts 44% of women with osteoporosis who will break a bone, and only 21% of men. And in fact, fracture risk depends on factors largely other than bone density. And I've just continued to learn and understand how we can improve patient outcomes, empower patients, give them the tools and the information to improve their health and reduce their fracture risk, maintain their bone strength. And since then, I've written over 100 research reviews and lectured at countless medical conferences. I have written 4 books. The most recent is Fracture Proof Your Bones: A Comprehensive Guide to Osteoporosis, and I'm on the Bone Health and Osteoporosis Foundation Corporate Advisory Roundtable, as well as having given talks at medical schools like GW Med School. And so it's really been an incredible journey. I'm proud that I am in this position now to be able to communicate to patients what they can do, because as you mentioned, osteoporosis is a very scary diagnosis. But as I tell patients when they come in to see me, that number on a test, that bone density test result, is not the most important thing. It is a piece of a much larger puzzle, and they're typically anxious when they come and see me. And so I have them take a few deep breaths, and I put that test in its proper context, and I let them know that there is time to create to create a holistic bone health program that makes sense for them. And it may or may not include medications, but there's time for them to educate themselves so they can make the best decisions possible for their health.
And you mentioned men as well as women. And it seems like in medicine, we're preoccupied with osteoporosis screening for women, and men kind of get ignored.
That's true. And 80% of osteoporosis cases are in women. And that's where the majority of the research dollars and emphasis and attention has gone to women with bone loss and osteoporosis. And the reason why it affects women more, and it's primarily postmenopausal osteoporosis, is what's been researched, is because when estrogen declines in perimenopause and for the 10 years after, that's when there's the fastest rate of bone loss. But even in that situation, it's important to understand for your listeners that a lot of women, they'll go in and see their doctor and they'll get a diagnosis of osteoporosis, and they're postmenopausal, and so the assumption is, well, it's just because your estrogen's gone down. But up to 30% of cases of women with postmenopausal osteoporosis, that bone loss is caused by other things, not just the drop in estrogen. So it's really important to get a more comprehensive evaluation to understand and identifying what the potential underlying causes are. And in men, about 20% of cases are in men. And yes, it's less common, but when a man does fracture, their risk of dying is twice what it is in women when they fracture a hip. When a woman with osteoporosis breaks her hip, there's up to a 36% chance of dying. Most often cited is 20%, and that's within a year. And men have a higher risk of dying if they were to fracture a hip. But regardless of whether it's a man or a woman, most people who are eligible for screening aren't even getting screened. 95% of eligible Medicare patients are not getting screened with a bone density test. And we know that osteoporosis is second only to cardiovascular disease as a global health risk. I mentioned the mortality risk if you were to fracture a hip, but a woman's risk of an osteoporosis fracture is equal to her combined risk of breast, uterine, and ovarian cancer. And if she has breast cancer and fractures a hip and ends up in the hospital, there's an 83% increased chance that she's going to die compared to somebody with breast cancer who has not broken a bone. And osteoporosis accounts for more days spent in a hospital than other diseases like heart attacks, breast cancer, diabetes, et cetera. It is these statistics are shocking to me. And they tend to be a surprise to most people because there aren't marathons and huge awareness campaigns to get people focused on this. So I hope one of the things that we're able to do today is to just get people more focused on this condition so that they can get screened if they haven't, so they understand the options and the resources available to them.
Absolutely. And I definitely want to touch on the causes. Like you said, there are other causes other than being postmenopausal that can lead to osteoporosis. But first, can you elaborate a little bit on why is osteoporosis associated with increased mortality risk?
It's because what happens is when somebody breaks a bone, and they tend to be older, 60s, 70s, 80s, they often have other conditions, comorbidities going on, and having other diseases increases the risk for dying. But also they are sedentary. So during recovery, there's an increased risk for blood clots. People's appetite can go down. So already if they're weak or they've had muscle loss or muscle wasting, and then they get even less nutrition, that increases the risk, and depression can set in. It tends to be, what I call the proverbial, last, straw that breaks the camel's back. It tends to be this event that starts this downward spiral in people.
Yeah. And I've seen where people have caught, like, by being in the hospital and not, or in a rehab, I've seen where they've caught pneumonia then, or, and they're not actively, taking big breaths because they're really not, because of the sedentary lifestyle and poor posture, laying in bed all day and whatnot too.
How do the cases of osteoporosis in the United States compare with the rest of the world? Are we better, worse?
That's a great question. So it depends on where you're looking at. First of all, the data globally is not that reliable. And I think overall globally, it's also underreported and understudied. So it's difficult, I think, to get really accurate data. The rates of osteoporosis in the United States, it's estimated that about 40% of women at some point are going to fracture due to osteoporosis. You have higher fracture risk in some other populations, basically that are aging. So the older the mean age, as the populations get older, that increases the risk. So part of it is just demographic shifts that we're seeing also globally with aging populations. In the Middle East and in areas where there is people tend to be covered and stay indoors. There are higher rates likely because of vitamin D deficiency that can develop. So it just depends the factors on where they are globally.
So I'd like to go ahead and touch back on the possible causes of osteoporosis, other than the like postmenopausal, as we discussed. Because I think, in your book, which I liked, is you wrote one of the, a list of questions that people need to ask their doctor. And one of them was, what kind of osteoporosis do I have?
Yeah, that's really important. So at the end of many of the chapters of the book, there are take action sections, and that gives people questions or things to think about or activities to do to make sure they're getting the information and making the best decisions for their own health. So in terms of osteoporosis, it's divided into two categories: primary versus secondary osteoporosis. And primary osteoporosis is what I already mentioned. It's that age-related decline in estrogen in women. In men, it's related to the age-related decline in testosterone. But secondary causes of osteoporosis, there are a lot of them. And I mentioned before that up to 30% of women with osteoporosis, even if they're postmenopausal, that condition is caused by something else besides the drop in estrogen. In men, it's up to 50% of cases. It's not just because testosterone has declined. There are other causes going on. So what are those causes? One of the most common that I see is medications. There is a long list of medications that damage bone and decreases bone density and increases fall risk and increases fracture risk. The most commonly prescribed medication, so antidepressants, anything that artificially increases serotonin, and about 25% of women over the age of 65 are on an antidepressant, and the most common antidepressants being prescribed are those that increase serotonin, like Prozac and Lexapro. And there are serotonin receptors on bone, and serotonin activates a cell in the bone called the osteoclast that breaks bone down. And now we know for women taking an SSRI for even just as short as 1 year, from the study was 1 to 5 years. For every 19 women taking that medication, we expect one to fracture. And most doctors don't understand that the medications they're prescribing are increasing fracture risk. And so it's really important to get a medication review and ask the question of your doctor, but also talk to the pharmacist. I really recommend people speak to their pharmacist and get a medication review from the pharmacist as well, specifically with a focus on bone health. Another category of very commonly prescribed medications are the proton pump inhibitors, those acid blockers. They can increase fracture risk by up to 60% or more. And in fact, most of those prescriptions are because of just one condition, which is acid reflux, which I think we all know can be treated often very effectively just with dietary changes. And yet half of those prescriptions for acid blocking medications are for that diet related condition. Instead of working on the underlying cause, they prescribe a medication that suppresses the acid. And in those cases, when somebody is taking it for acid reflux, their risk of fracture actually goes up by 350% compared to people taking the medication for other causes. And I think it's important because to understand the secondary causes that may be creating the osteoporosis, because when it comes to medications that are prescribed for osteoporosis, it's often, in fact, almost never, I think, taken into account that the research for the approval of the medication, most medications, is on postmenopausal osteoporosis. And the general thinking in the medical community is, well, if somebody has bone loss because of osteoporosis, it doesn't really matter why they have bone loss for these other things. We're just going to be prescribing the drug for other causes, other types of osteoporosis as well, despite the fact that the mechanism of action is totally different. And what they found out when they were studied this with the acid blocking medications, because they were prescribing Fosamax and bisphosphonate medications, they discovered that they were actually hurting people. When somebody took an acid blocker with the bisphosphonate, their risk for fractures increase was actually higher than somebody who was just taking the bisphosphonate without the acid blocking medication. So that's a thing that I go over in the book, where it's really important to ask, what type of osteoporosis do I have, and is the medication, has it been studied in people with my medical history, with my diagnosis? Other secondary causes are those comorbidities, those other diseases that people have. And back to the medications briefly, there's a list of medications in my book as well, because there are many more than what I mentioned. These other secondary causes in chronic inflammation, chronic inflammatory diseases like irritable bowel disease, ulcerative colitis, cancers and cancer treatments, other things like autoimmune diseases, all of these predispose and increase the risk for bone loss, osteoporosis, and fractures.
Does diabetes have any effect on osteoporosis?
The TZD medications do. Diabetes is associated with an increased risk for bone loss. Yes.
Yeah.
Wow. And, a question I get asked a lot, well, I guess it's not even a question. I think people assume, they're like, oh, my mother had osteoporosis. It's, so I'm going to get it. And, from my knowledge, there's not much data out there on that. Can you explain, is osteoporosis genetic?
As we get older, genes are less important. And what's more important is environment, diet, lifestyle, exercise. And research has continually, concluded that there is no genetic cause for age-related or secondary osteoporosis. I mean, there is to some bone diseases that show up in pediatric populations. But as people get older, the sort of run-of-the-mill age-related osteoporosis, there is nothing determinative genetically that has been shown at this point. But I'd also like to say, and most importantly, because family history is a risk factor for osteoporosis, and in fact, it's one of the things that's asked is, did your mother have osteoporosis to a woman? If the answer is yes, and they're at a higher risk for osteoporosis. But the reason is not because of genetics. The reason is because we tend to inherit the diet and lifestyle of our parents. And that's more determinative than genetics for age-related osteoporosis.
I'm really glad you touched on that. And I think that goes right into the next topic of, can you maybe touch on lifestyle and how important diet and exercise is to maybe prevent and reverse osteoporosis?
And other things like sleep and stress too.
Yeah, this holistic approach is really important. And when you're doing things that are, stacking the deck in your favor, that are pushing your biochemistry and your physiology in the direction of health, and you're taking this holistic approach, using those foundational things like diet, lifestyle, stress management, sleep, exercise, not only can it improve your bone health and reduce your fracture risk, but it also reduces your risk for heart disease, Alzheimer's, diabetes, obesity, cancer, death from cancer. I mean, the list just goes on and on and on. So what are some of those approaches? So first of all, diet and lifestyle. That's always and should always be the foundation of every approach to bone health and osteoporosis. Unfortunately, conventionally, that's not the case. People go in and they're typically just prescribed a medication, and they're said, okay, well, eat healthy and start exercising. But it's not prescriptive, and doctors by and large are not educated, the conventionally trained doctors, on how to have those more nuanced, longer conversations. And so people are left to their own devices. So what does the research show? The Mediterranean dietary pattern, which is a plant-forward diet, is associated with a 21% reduction in hip fractures, which is the most dangerous type of fracture, and a 20% reduction in osteoporosis. So the more somebody adheres to that dietary pattern, which is lots of whole foods, lean proteins like chicken and fish, grains, the more they adhere to that, the healthier they're going to be. There's not one negative study that's looked at the Mediterranean dietary pattern over 7 or 8 decades of research showing that it reduces the risk for heart disease, diabetes, everything I mentioned before, all-cause mortality even. So that's what I advocate. Now, what's often missing from that conversation is ensuring that you're getting enough protein. The bone is a highly protein dependent tissue. There are 180 to 200 different proteins in bone, and it's actually the protein, as one of those is collagen, that gives bone its ultimate strength and flexibility to withstand the impact of a fall and not break. So making the amount of protein somebody consumes can account for 2 to 3% of bone density alone, and ensuring that. So I like to tell people, take your body weight in pounds, multiply it by 0.6, and that's the number of grams approximately minimum of protein that they should be consuming per day. Exercise, really important, but you don't have to go into a gym. Sure, if you like to go into a gym and lift weights and you're able to do it safely, fantastic. But really, it's about what exercise you're going to be able to do consistently. Now, this is typically a condition that's taken decades to develop. So it's going to take time to move back into the direction of health and reestablish that balance and that foundation of health in their bodies. So doing exercise consistently, gardening can be fantastic. Even just walking, 7,000 to 7,500 steps per day on average is associated with a 50 to 70% reduction in all-cause mortality. Anything that can improve balance. So I like to teach people the stork exercise. It's in my book. You stand on one foot while you are brushing your teeth, your bottom teeth, and you switch feet, and you stand on the other leg while you're brushing your top teeth, and you do that. That's 2 minutes per day. And that can increase a little bit of your balance, because 95% of fractures happen because somebody falls. So anything we can do to improve balance, strength, and stability, reduce the risk for falls, is going to reduce the risk for fractures. Sleep is also important. What the research shows is that people with insomnia, if they're getting an average of less than 6 hours of sleep a night, they lose bone faster and they're at a higher risk for osteoporosis. And in fact, a study in the UK showed that a large percentage of fractures, osteoporosis fractures, are due to poor sleep. And other research has shown that sleep is as dangerous as drunk driving when it comes to people's coordination and reaction time. So improving somebody's sleep is really important. Stress management is important, because even if people are still just in the normal range of cortisol, that stress hormone, a study was done showing that people who are in the normal range but towards the high end of normal, so nothing pathological, nothing that would have your doctor refer you to an endocrinologist for additional workup, but just being in the upper end of normal for cortisol, meaning you're living a high stress life, is associated with a faster rate of bone loss. So any of these modifications that people can do holistically to then begin to give the body the environment, create the environment in which your body can build and thrive, the better off you're going to be, because our biochemistry wants to do what it wants to do. It's like a plant that wants to grow in the soil. When you give that soil the nutrients, the water, the environment that it needs to grow, it's just going to do what it is genetically programmed and wired to do, just like our biochemistry. It's going to help you be healthier.
You mentioned collagen. What do you think of collagen supplements?
I think research has shown that hydrolyzed collagen can improve bone density. It also reduces a marker on a test called CTX. CTX is a breakdown product of collagen. So when CTX is high, it's indicating you've got a higher rate or more collagen breaking down. So if it's high, we want to see that number coming down. And collagen can reduce that, as can other things like MK4 and vitamin D, nutrients in my line of bone support products. So yeah, I'm a fan of collagen. It's not my first line in terms of supplementation, but it is definitely there and an important thing to consider.
So since we're talking about supplements, what do you target their vitamin D level at? Because the reference range is horrible, right? It's like 30 to 100.
Yeah. So I've even seen lower than that, but the associated with the lowest fracture risk is a vitamin D level of 30 to 44 nanograms per milliliter. So that's what I target just for bone health. But, for immune health, we want much higher, 60, 70. And so just the minimum, when I'm looking for bone health, I definitely want it to be within that 30 to 44 range, because that is associated with the greatest reduction in hip fractures and the greatest reduction in falls. But I often, want it higher because I want other benefits as well.
And then we always recommend vitamin D with K2. And we know that there's different forms of K2. And you mentioned it a little bit earlier, but can you expand on that?
Yeah, there are different forms of vitamin K2 as a category of nutrients. I think a lot of people aren't quite aware of that. There are two forms that are commercially available, MK4, called MK4 and MK7. MK7 is by far the more popular nutrient in dietary supplements. In fact, every dietary supplement on the market that combines D3 and K2 uses the MK7 form of vitamin K2. My product is the only one in the country. My line of products, I have 3 versions of it that combine the vitamin D3 with MK4, and I'll explain why in a moment. But when I'm looking at the research on nutrients, dietary supplements, interventions that we can do, I want to look at data that shows that in clinical trials, it maintains bone strength. It doesn't improve a number on a test, or that bone density test number, but it actually they're looking at the most clinically relevant or the most clinically important variable, and that is fractures. That's the most important indicator of whether somebody's bones are strong, if they fall and they don't break. MK7, even when you're just talking about bone density, in any dose, MK7 only slows down how fast somebody loses bone density. It's never been shown in any clinical trial to stop or reverse bone density loss. And in fact, in one study, the women taking the MK7, they had faster bone loss at the hip than the placebo group or the control group. And with fractures, there are no studies that have looked at MK7 for fractures. In contrast, MK4 in the dose of 45 milligrams per day has been shown to not just stop bone loss, but improve bone density in women with postmenopausal osteoporosis. Also been shown to stop bone loss in people taking prednisone, androgen deprivation therapy in men, and even in children and adults with chronic kidney disease on hemodialysis. So the research is strong and unambiguous when it comes to improving bone density with MK4 45 milligrams per day. But more importantly, it's been shown to reduce fractures in clinical trials of postmenopausal women with osteoporosis by over 70%. There are over 25 clinical trials with that. And when you combine the MK4 with the D3, the effect and the benefits on bone density are even greater. And this was my frustration, 20 years ago, working with patients, and I was discovering this research and trying to figure out how to help them. And there's no product on the market that had the doses shown in clinical trials to work. And that's why I started my company, NBI, and created these OsteoK line of bone support products, because I couldn't find the clinical trial doses shown to work in existing products, and I needed them to help my patients. And I've grown the line and continue to research that since then. But that's how I evaluate, MK7 versus MK4. Most of the literature out there, or the claims with MK7, it'll talk about how it changes a laboratory marker like undercarboxylated osteocalcin, or it's better absorbed, or it has a longer half-life, therefore MK7 is better. None of that is clinically relevant. And the most clinically relevant thing is, do people have strong bones, and are they breaking? And that's where the MK4 is the only form of vitamin K2, and in the dose of 45 milligrams per day in divided doses, that's been shown to be effective. And that's why it's in my products.
And the other supplement that people talk about is calcium. What's your feeling on calcium?
I think calcium should be definitely dosed with a thought of making sure they're not getting too much. You can get too much calcium. So the current Bone Health and Osteoporosis Foundation and American Academy for Preventative Cardiology, their consensus statement is that you should not get more than 2,000 to 2,500 milligrams per day of calcium. Otherwise, it can be dangerous. And the US RDA for calcium for women is 1,200 milligrams per day. For men, it's 1,000 milligrams per day. And it's important to understand that that's from all sources, diet and dietary supplements. The average American woman gets about 800 milligrams of calcium in her diet. So she shouldn't really need more than 400 milligrams as a dietary supplement. And even if she's getting, more calcium in her diet, because she's hopefully eating better than the average American, that even if she were to get 400 milligrams, it's still well within that safe range of calcium. And for men, on average, getting 1,000 milligrams of calcium from their diet, they typically won't need additional calcium as a dietary supplement. But I continue, unfortunately, to see patients being recommended doses of 1,000, 1,200, 1,500 milligrams, and the current understanding is that up to 1,000 milligrams per day of calcium as a dietary supplement is safe. But I think you need to take the amount of calcium in the diet into consideration when understanding how much somebody should be taking as a supplement. And with respect to bone health and fractures, calcium alone has not been shown to reduce fractures, and same with vitamin D. It's when they're combined. The two work synergistically. So it's calcium and vitamin D have been shown to reduce fractures by about 18 to 23%. But when we add that MK4 into that mixture, 45 milligrams per day, then that jumps way up to, we're talking over 70% reduction of fractures in clinical trials.
Now, what about, there's minerals that are very important as well. Like I'm a fan of, I do some mineral drops in my water every day that also involve like boron. But what about like strontium? Is that something you're a fan of, or do you have a different opinion?
Yeah, before I answer that quickly, I just want to mention one more thing on my products, because I think that it is important to note. The research is so convincing. I'm so convinced. And I've been having these products on the market for now almost 20 years, that we developed what's called the Strong Bones Guarantee. That we guarantee that if you take any of our NBI's bone support products, your bone density will stabilize or improve within 6 months. But more importantly, if someone breaks a bone, we will refund their money for all qualifying purchases between their bone density tests.
Wow.
That's how compelling the evidence is. I want to, we're putting our money where the research is, where our mouth is, and just not talking platitudes about this nutrients, but saying, look, we're so convinced. I am so convinced as the founder and owner of this company with a passion to helping people, that I guarantee it. And if you are not getting the results, then we have a mechanism in place for people to submit for review and to get those that money refunded to them if necessary. So that's important to understand, because no other company is offering any guarantee on any product like that. And it upsets me that so many companies out there are touting their products and they're just showing bone density improvements, and they have no clinical trials on the nutrients showing that it actually reduces fractures and it maintains strong bones by reducing fractures. And instead, they're looking at this test number that only predicts 44% of women with osteoporosis who will break a bone. So with respect to strontium, yes, boron, other minerals, those are great questions. I'm not a fan of strontium for several reasons. One, first of all, strontium has been shown to reduce fractures. And that's important, because that's like the top of my list. That's the most important thing. But it's not the only thing. A nutrient also has to be safe. And all the research in strontium that's been done on strontium was done in Europe on a form of strontium called strontium ranelate, which is a medication prescribed in Europe for osteoporosis. In the United States, that's not available. In the United States, the nutrient strontium is available as a dietary supplement as strontium citrate. Now, there are no clinical trials on strontium citrate showing it's safe or effective. And let's just we can assume for a moment that it's just equally as safe and equally as effective as strontium ranelate. I like to be very honest and transparent about what the research shows and what it doesn't, what we know and what we don't know. So let's just assume that strontium citrate, the dietary supplement, is equally safe and equally effective as strontium ranelate. What does the research show for strontium ranelate? There are 6 large clinical trials. Only five of the 6 clinical trials showed that it only reduced vertebral fracture risk by about 45%, which is about equal to Fosamax. And only one of the studies showed hip fractures reduction. So it's doubtful that it reduces hip fractures. The second thing, importantly to know, is that it incorporates into bone, and it's a mineral, like calcium is a mineral. So when you get a bone density test, it's an X-ray. The X-rays bounce off those minerals, and when you have strontium in there, it gives a false bone density test result. So the bone density test that you're looking at, the result is inaccurate. Despite the limitation of the test, I do want my test to be as accurate as possible. And the third thing that I think is really important is the safety. What do we know for strontium ranelate? In post-marketing surveillance data in Europe, what they discovered is that for every fracture that was prevented, it created a blood clot in the lungs or the back of the legs. It can cause a stroke or heart attack. So for every patient that it was helping, it was potentially killing another patient. And I think that's really important. And as I said, there are no safety clinical trials on strontium citrate. So we can only assume that, perhaps the safety and effectiveness are the same as strontium ranelate. And if that's the case, for those reasons, I do not recommend strontium.
Thank you. Thank you for, I guess, making us aware of that, So I want to dive right into kind of, you touch on the accuracy of a bone density scan. So one of my pet peeves is, we do have the access to prescribed traditional medications like bisphosphonates, Prolia. There's one that's Evenity. And through that process, I have learned about the remodeling of bone, right? And you already touched on like osteoclasts, how they break down bone. And then we have osteoblasts that can rebuild bone. But those are mostly on the outside. The one thing I hate about a bone density is it doesn't really show the matrix on the inside of your bones, which is more of the actual thickening of the bone. So can you maybe touch more on like what a bone density scan shows, and then maybe what a FRAX score is?
Yes. So bone density test typically shows, like like the name implies, the density of the bone mineral density, the amount of minerals in bone. But bone is a complex tissue. It's not just minerals. I already mentioned the collagen and proteins in bone. It's made up of a lot of different components. The thicker outer, stiffer layer of bone is typically what then is tested with a bone density test. It's that spongy inner part of the bone, center of the bone. And by the way, the bone does much more than just letting us stand up and run and hug our loved ones and do all the things we love to do. It also produces our red blood cells, white blood cells, and platelets. It's an incredibly important dynamic tissue in our body, important for the immune system, cardiovascular system. And when you're looking at the bone density test, it's just looking at that mineral component of the bone. It's not giving a real accurate or holistic measure of the health or the strength of the bone. There is some indication that with a bone density test, there are other types of technologies out there that exist, like a CT scan, an ultrasound. That at this point, nothing, everything is tested and measured against a bone density test, and nothing has been shown to be superior to a bone density test for predicting fractures. And there's an emerging technology called REMS, which holds promise, but I think it needs at least 1 or 2 more validation studies on it. But that may end up eventually supplanting the bone density test as a better indicator for bone strength and what we can do to help improve that. A FRAX is a free online test that people can go to. And they put in different demographic information like their sex and their age and where also they live. It's based on all the different databases are based on where the country that people are in. They can put in a bone density test result if they have it. There are certain medications that'll ask you if you're taking like prednisone, but not the extensive list that we know now damages bones. So there's a lot of limitations to the FRAX, uh, the FRAX questionnaire.
Right.
It stands for Fracture Risk Assessment, and it can predict fracture risk and give you a 10-year risk of a fracture. But I think that really needs to be viewed with some serious limitations, and people understand the limitations of that. It doesn't ask you, it asks you about smoking, but it doesn't ask you about the exercise you're doing. It doesn't ask you about sleep. It doesn't ask you an extensive list of medications you may be taking, or many of the other diseases. It does ask about a couple of diseases, but there are lots of other diseases that damage bone and cause osteoporosis. So it has its limitations as well. It's not validated for people, under 50. And also, if you have had certain procedures like a stem cell transplant, it hasn't been validated in that population either. So there's just those nuances are really important to understand. It's a tool. And I think, like any of the tests out there and the tools out there, the greatest benefit that they give is that it helps people focus on the issue. It makes them aware of the issue. But despite whatever the results of any of those tests are, fracture risk still depends largely on factors other than any of the tests.
Thank you.
Can you talk a little bit about hormone replacement in men and women as far as
a huge fan.
fracture risk?
Yeah. So HRT in women, estrogen replacement has been shown is associated with a 28% reduction in hip fracture risk, which is great. So that evidence is there. The evidence is supporting starting hormone replacement therapy during perimenopause and up to the age of 60. There's no data after age of 60 or if people started after age 60. I personally don't understand why it still wouldn't help, but that's the current state of the knowledge. With men, often you have a reduction in testosterone as we get older, and that can then lead to bone loss and osteoporosis. And so testosterone replacement therapy is associated with improvement in bone density, like with the osteoporosis medications. However, there's less data in men in osteoporosis and HRT than there is with women with osteoporosis and HRT. So we're assuming that also fractures are reduced in men over the long run, but it's not just the testosterone. Estradiol in men, a form of estrogen, also plays an important role. It's often not thought about in men, but it's the estradiol that is also anabolic, and that is the primary hormone responsible in men and women for maintaining bone and improving bone health. So with men, you really want to get tested if they're getting their testosterone. They're on testosterone replacement therapy. They need to test also estradiol, and an estradiol level of over 20 is what is in the literature showing to be associated with the best outcomes when it comes to bone and bone density. Interestingly, with men, initially when they start testosterone replacement therapy, over the first year, couple of years, their fracture risk actually goes up. But it's not because of the testosterone. What the researchers have found is that it's because what men are feeling better, so they're feeling younger, and we tend to do dumb things and take greater risks, and so they're out there doing things that they couldn't do before because they felt so horrible because their testosterone was going down, and now they have more energy and their mood is up, and so they're doing riskier behaviors that increase their risk for breaking bone. It's not because of the hormone itself.
So you're not a fan of estrogen blockers in men like anastrozole, because we see so many patients come to our practice who are on testosterone and a blocker.
So I am if it gets too high. So I think that's where measuring estradiol is important, and I think pulsatile dosing of the aromatase inhibitor like anastrozole in men is a good clinical strategy. So if it tests too high, if it's above 40, different docs have their sweet spot that they like it to be, or if they've got some breast tenderness or gynecomastia going on, then decreasing that estradiol while maintaining that target testosterone level, is important. But I don't think men don't need to be on that at a continual dose. And if you can always just bring the testosterone dosage down a little bit also to reduce that estradiol.
Right. Well, Dr. Neustadt, this was phenomenal. I really appreciate you talking about the holistic approach to osteoporosis and how we can try to prevent or reverse it. Can you please tell our audience how they can find you and your products?
Right, and get your supplements.
Best place is on my website, nbihealth.com. Stands for Nutritional Biochemistry Incorporated, nbihealth.com. Everything's on there, articles of mine, those free resources, products, my book, information about me and my research. It's all on there, and links to our social media channels as well. And my podcast is also on there.
Awesome. And I'll also post all that in the show notes. Thank you so much.
Yeah, this was great. Thank you. The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.